We will start the session on taming the iris in cataract surgery. The first talk is by Dr. KALAIMATHI. She is a senior consultant at Giridhar Eye Hospital, Kochi. Over to you, Dr. KALAIMATHI.
Thank you, Dr. Sara. My topic is dealing with floppy iris. To begin with, the pupil looks normal and the iris is, pupil is well dilated to begin with. And when we do the hydrodissection, the pupil becomes constricted and the iris starts behaving little differently. And this is where we should think that we are dealing with floppy iris syndrome. So why is this important? Why is it important to identify IFIS? This increases the risk of cataract surgery by 5-fold. So it is more associated in men who is using tamsulosin for BPH, and this drug is being used in women for urinary retention as well. And it happens even after a single dose of this medication, and discontinuation of this medication does not eliminate IFIS. So this condition occurs in if the same class of other medicines also is used. Hypertension, diabetes, and antihypertensive drugs like losartan also can cause this condition. And pupillary dilatation less than 7 millimeter, and other drugs like benzodiazepines, antipsychotics, antidepressants, they also can predispose to this condition. So how do you know that it is going to be a problem for you in cataract surgery? There is no perfect way to know that IFIS is going to happen. One of the signs is poor pupillary dilatation. That is the reason why it is called intraoperative floppy iris. So knowing the history is important. The history of tamsulosin use should be asked in every patient. So what is this floppy iris syndrome? Why it can be a problem? So intraoperative floppy iris syndrome, that is IFIS, was described by Chang and Campbell in 2005. It consists of 3 components, that is iris billowing to intraocular fluid currents, pupillary constriction, and iris prolapse towards incisions. So it is complete if all 3 features are present, and incomplete when even one feature is missing. So what is our aim during our cataract surgery? The aim is to keep the pupil well dilated and to stabilize the iris. And how can this be achieved? It can be achieved by drugs, the iris hooks or expansion rings, and OVDs. So pre-operatively, we have to use atropine 1% eye drops 2 times daily for 2 days, and NSAIDs 3 times daily for 2 days. So we have to keep all these items ready before surgery, that is adrenaline for intracameral use, Oculan, that is lidocaine for intracameral use, and phenocaine, which is a combination of lidocaine, tropicamide, and phenylephrine for intracameral use. And we also should keep ready OVDs like Viscoat or Orocoat, Cohivisc, and HPMC, and iris hooks or B-hex rings. So coming to the surgery proper, it is always better to use peribulbar or subtenon anesthesia instead of topical anesthesia. And small side ports with long intracorneal tunnel is preferred. Here we are using 1 mm clear cut side port knife, and use of intracameral adrenaline is always advised to maintain the pupillary dilatation. And stain the capsule with trypan blue, because in case if the pupil comes down later on, we can visualize the anterior capsule. And the CCC should be at least 5 mm diameter, and the main wound should be 2.4 to 2.8 millimeter incision, and it again should be a long corneal tunnel. And coming to the hydrodissection should be as gentle as possible, and as less fluid as possible in multiple quadrants, so that because it is after this step the cascade of reaction starts and the iris starts behaving differently. The intracapsular bag pressure should be kept minimum always, and the nucleus is nudged, and the trapped fluid should be released, and the mobility of the nucleus should be confirmed. Mobility is confirmed. Now coming to the phaco proper, low flow, low pressure phaco is advised because the main aim here is to there should not be any turbulence while inside the anterior chamber, and the plane of emulsification should be the anterior plane so that the iris should not come out, and minimal in and out movements of the phaco probe should be there should be emulsify, and only then you have to come out so that the iris doesn't come out through the incisions. These are placed over the iris so that it doesn't prolapse out. And it is always better to do a divide and conquer technique. And here the dispersive OVDs are placed, injected first, followed by HPMC beneath it. So while irrigation and aspiration, it can be done either bimanually or by coaxial method. If bimanually, if you are doing the irrigation port should be above the iris, and while lens insertion, the everything should be maintained above the iris plane. The bevel should, it's better to keep the bevel upward so that the iris doesn't get caught in the bevel. If the hooks are used in case of iris, it's better to use 5 hooks, and the 5th hook should be placed below and behind the main incision. This avoids tenting up of the iris and increases the visibility. And in case of iris, sphincterotomies and mechanical pupil stretching should be avoided. If iris gets plugged in the side port, it is better to complete the phaco with that. And if iris prolapses out after the IOL implantation, intracameral meiotic agents such as pilocarpine can be given. While repositing the iris, its gentle pressure should be given posterior to the wound, so that it goes inside, and after that OVD should be placed over the iris to prevent it from further prolapsing. So IFIS remains a challenge for the cataract surgeon always. PCR, the rate of PCR is 7 to 12%, and if adequate measures are taken, it can be brought down to 0. So long-term complications include pupil deformity, which can give rise to glare later on, and macular edema, peripheral anterior synovial formation, and angle closure glaucoma are the common complications. So take-home points are use of preoperative atropine and NSIDs, small side ports with long intracorneal tunnel, dispersive OVDs, and gentle hydrodissection with low fluidics, and anterior plane phacoemulsification. Thank you.
Thank you, Dr. Kalai. So I would like to ask you, we are proceeding with phaco and immediately in midway IFIS occurs. Then how will you proceed?
Okay, during intraoperatively.
Initially we didn't put any pupil expanders.
Okay.
But midway the iris starts billowing and coming out of all the ports.
Yeah.
Then how will you proceed?
Yes, then I'll use the dispersive OVDs. You mean to say the side ports are all bigger? We didn't plan for it. Is it?
The patient was prone for IFIS, but as the pupil was almost 70% dilated, we didn't put any pupil expansion devices.
Okay.
But midway the pupil started shutting down.
Coming down. Okay. So I might try without pupillary, dilatation. If I am not able to do it, then I'll start using iris hooks.
So after capsulorhexis, if you are using iris hooks, what precaution you will take?
I'll inject OVDs between the iris and the capsule, and I'll put the iris hooks.
So
And initially I'll try without iris hook. If I'm not able to do it only, then I'll proceed with iris.
With viscode dispersive OVD,
Yes.
you will try to
Yes.
keep the iris in place.
Yeah.
If we have to inject iris hooks, we should visualize the capsulorhexis margin
Yes.
very clearly.
Yes.
Otherwise, the rhexis can extend.
Yes.
Have you any experience with using atropine pre-op?
I
Does it
tried
help?
atropine, but post-operatively the effect was that the patient was not happy.
Any questions?
So I don't think pharmacodialysis is actually going to maintain the dialysis during the intraoperative manipulations.
Yes, sir.
So my take is, if you are seeing that iris billowing, iris prolapsing through the side port, immediately go ahead and put hooks. If you have already started. If you are doing it primarily before the rhexis is done, I prefer to do a B-hex, provided the anterior chamber is deep, about 3 millimeters. Shallow anterior chamber, I will not use a B-hex. It's very difficult to manipulate. One most important thing is to ensure that there is a hook under the phaco port. Okay, because if that retracts the iris out of the way, there is no iris chafing. The iris itself is very billowy, and it will come towards wherever there is least resistance or wherever there is vacuum. So during phaco, you may feel that it is 5 millimeters, I may be able to manage, but then suddenly it will go into the phaco port, and then you will end up with iris chafing, very distorted pupil, and it gives a very poor outcome, especially if it is a premium IOL multifocal or something like that.
Okay.
So mechanical dilatation is the best way to go for it.
Okay.
So just one more point to add. If the iris has already prolapsed, and when you are entering the eye with the phaco probe, it's better to switch off the flow and then enter the anterior chamber. So that will reduce further iris prolapse.